Serological detection of bacterial infections. So for laboratory detection of bacterial infections, there's a couple different things that we do. We would culture the causative agent. We would do a microscopic examination, like gram stains or special stains. We can do immunology, so detect bacterial antigens using antibodies, or detect antibodies within the patient to see if they've been exposed or have immunity against a particular pathogen. And then we can also do molecular detection of bacterial DNA or RNA and can obtain the results within a few hours with PCR. All of these four are still commonly performed in the clinical microbiology lab, although a lot of the culture-based tests are going away and being replaced by more of the molecular type tests. So serology detects antibodies to bacterial antigens. Uses: to detect and confirm infections for which other laboratory methods are not available. So if we can't culture it, we can look for antibodies against it to confirm that the patient's been exposed. To diagnose infections for which clinical symptoms are non-specific. Current infection initiated by the presence of IgM, a high IgG titer, or a fourfold rise in antibody titer between acute and convalescent samples. To determine a past exposure to an organism. To assess reactivation or re-exposure. Some disadvantages are the delay between the start of the infection and the production of antibodies, so we can't tell right away what the patient has based on serology because it takes a while for them to develop antibodies against it. Also, low antibody production by immunosuppressed patients. Another disadvantage that I'd like to throw in here is that sometimes we can't tell if a patient has an active infection or a previous infection. Now, we can sometimes distinguish the IgMs versus the IgGs, but sometimes having a lot of IgGs could indicate a current active infection, or it could indicate previous exposure, so sometimes it's hard to tell the difference. So group A, strep. Gram-positive cocci arranged in pairs or chains, person-to-person transmission. Some of the common clinical manifestations would be pharyngitis, pyoderma, scarlet fever, toxic shock syndrome, necrotizing fasciitis, typically treated with antibiotics. We would usually start with a culture, but then there's the rapid assay to detect strep. So if we think that a patient has strep throat, we would swab their throat and then use a lateral flow assay. So when we put the sample in here, typically the sample would be put into the bottom, and then we would have some type of reagent that would allow this to flow through by capillary action. And then there would be capture antibodies on the test strip. One of the capture antibodies would be looking for just any typical human protein, and that would be in the control line. And then the other capture line would be specific for strep. So if it turned positive for both lines, then it would be positive. If the sample was negative but the control line was still positive, this would be our negative result. There's also the anti-streptolysin O. Nephelometric methods currently used that measure light scatter produced by immune complexes containing streptolysin antigen. Titer elevated in 85% of patients with acute rheumatic fever. Does not increase in patients with skin infection. Anti-DNase B, produced by both rheumatic fever and impetigo patients. It's tested by enzyme immunoassay and nephelometric methods. The streptozyme test detects antibodies to 5 streptococcal products. And then the Helicobacter pylori test. So this is a gram-negative microaerophilic spiral bacterium. Transmission is likely by fecal-oral route, major cause of gastric and duodenal ulcers. It can survive in the acid environment of the stomach because of the production of urease, which provides a buffering zone around the bacteria. Treatment with antibiotics and anti-ulcer medications are necessary, but if left untreated, it can lead to gastric carcinoma or mucosal-associated lymphoid tumors. Do the urea breath test, or look for H. pylori antigens or H. pylori antibodies. Bacterium in here, and we would incubate these at a higher temperature because they like to grow at high temperatures. If it doesn't change color, it would be negative. If it does change color, it's positive. and that indicates the likely presence of Helicobacter pylori. Mycoplasma pneumoniae, tiny bacteria that lack a cell wall. They're the leading cause of respiratory infections: fever, headache, malaise, cough, walking pneumonia. Raynaud syndrome causes Stevens-Johnson syndrome in a minority of cases, and it's spread by respiratory droplets. We can culture this one, but we can also look for antibodies to the M. pneumoniae. Most useful diagnostic assay, IgM antibodies indicate a recent infection. IgG antibodies indicate a possible infection. Cold agglutinins are present in about 50% of patients with M. pneumoniae, but it's not specific for the infection. Causes red blood cell agglutination at 4 degrees Celsius, and it's reversible at 37. There's also molecular methods available. Rickettsial infections. So it's an obligate intracellular gram-negative bacterium. It's in the spotted fever group, so Rocky Mountain spotted fever. And then there's the typhus group, epidemic typhus. Organisms are transmitted by arthropods, such as ticks, mites, lice, or fleas, through biting after feeding on an infected animal. Rocky Mountain spotted fever is caused by R. rickettsia, transmitted by 3 species of ticks. Symptoms include headache, nausea, vomiting, diarrhea, skin rash, and death. Diagnosis, clinical presentation, and serology by immunofluorescence assay. And then you can review the summary there. And now we're going to specifically focus on the spirochetes that cause infection. So syphilis is one of the major spirochetes that causes infection. It is a sexually transmitted disease that's caused by the spirochete bacterium Treponema pallidum. So Treponema pallidum causes syphilis, rapidly destroyed by heat, cold, and drying. Direct contact with open lesion is needed. Transmission to the fetus during pregnancy is also a concern. Bloodborne transmission is rare. So the clinical manifestation goes through several phases. The primary stage is the development of the canker. This canker is the only time that you can actually access the spirochete. If you do have the presence of the canker, then you can swab and you can do fluorescent microscopy. And you can even use fluorescent antibodies to specifically bind to this, and then you can see it under the microscope. If the lesion is closed, the secondary stage and other stages are not able to be visualized as easy. So in the secondary stage, the canker will completely heal up, and now the spirochete has been traveled through the blood and into the lymphatic system. You have generalized lymphadenopathy, malaise, fever, pharyngitis, and a rash. This rash is pretty obvious. So you see this rash over a big chunk of the body, and it's a bright, glowing, flaming red rash. As I mentioned, you can't see the spirochete anymore, so a lot of times we just have serological testing. The latent stage is asymptomatic, so then the patient can go into latent stage for many, many years, and then all of a sudden they progress into the tertiary stage. Gomatis, cardiovascular, and neurosyphilis. You start to see these big, huge sores open up on the outside of the body, and they can even present themselves on internal organs. They can have neurological symptoms, so they start to go crazy, start to have symptoms of dementia, and all sorts of significant symptoms. Mortality rate is extremely high once it progresses to the tertiary stage. It's effectively treated with antibiotics, so if the canker is seen, typically like 99% of cases will heal completely if treated with antibiotics. If the canker is ignored, and sometimes the canker can hide in like spots that aren't easily seen, and you can ignore it and it does heal and it's not painful, so when it goes away you're just like, oh, maybe I'm better. But then when you start to see the rash all over the body, that's kind of your tip to go get antibiotic treatment. If you ignore that rash, because that rash will eventually go away too, then it can progress to tertiary stage. Congenital syphilis is when a baby is born with it. Transmission of treponemes into the fetus occurs when the pregnant woman has early stage or latent syphilis. It causes death in 10% of cases. Live-born infants may be asymptomatic at birth but develop symptoms later, such as a runny nose, skin rash, generalized lymphadenopathy, hepatosplenomegaly, so enlarged liver and spleen, jaundice, anemia, bone abnormalities, and neurosyphilis. Direct detection of syphilis, or laboratory diagnosis of syphilis, we have direct detection, demonstration of treponemes in an active lesion, dark field microscopy, or fluorescence. Detect the antibody against cardiolipin, or reagent, a lipid released from membranes of cells damaged as a result of the infection. The Venereal Disease Research Laboratory Test, VDRL, the Rapid Plasma Reagent, RPR test. You can look for flocculation, screen, the test is undiluted patient serum, and titer, test twofold dilutions of the patient serum. So going through the VDRL test, patient serum is mixed on a slide with cardiolipin, lecithin, cholesterol antigen suspension. It's rotated for 4 minutes at 180 RPM, viewed under light microscope for flocculation. Results are compared to the controls. Reactive would be medium to large clumps, weakly reactive would be small clumps, and non-reactive would be no clumps or slight roughness. The RPR test, patient serum is mixed on a card with charcoal particles coated with cardiolipin antigen. You rotate it for 8 minutes at 100 RPM and observe for macroscopic flocculation. Flocculation is just clumping. So here you can see what it looks like when it's reactive, weak reactive, and non-reactive. Here you can see that it's reactive even when the patient's undiluted, and as you dilute it down, it's still reactive for quite a bit of time. So this would be a positive test. Treponemal tests. So non-treponemal means you're not actually testing for the organism isn't actually present. You're just doing immunological testing to see if they've been exposed to it. Treponemal means that the organism is present, and that usually can only be found in really early samples from that canker. You detect the antibody to T. pallidum, fluorescent treponemal absorption test, T. pallidum particle agglutination, automated immunoassays like the ELISA, the chemiluminescent immunoassays, or the multiplexed flow immunoassays. FTA antibodies test, an indirect immunofluorescence test for the antibody to T. pallidum. The procedure, the patient's serum is incubated with sorbent, an extract of non-pathogenic treponemes, to remove cross-reacting antibodies. Absorbed patient serum is incubated with microscopic slide to fixed with T. pallidum. Following a wash, anti-human IgG conjugated with fluorescein is added. After a second incubation and wash, slides are examined under a fluorescent microscope. Patient serums and controls. So for the TPPA test, patient serums and controls are diluted and incubated with unsensitized gel particles or gel particles sensitized with T. pallidum antigen. A positive test would be agglutination. Negative test, no agglutination. So you'd see the button in the center of the well. And here's just a diagram of those tests that were mentioned previously. Typical antibody pattern in syphilis. So here you can see the treponemal antibody tests. Those will detect it. The percentage of patients who test positive is pretty high. And then you see the non-treponemal antibody test, the RPR or VDRL. If they were treated, you should see those go down. Left untreated, they should stabilize but still be higher than if treated. Traditional testing algorithm for syphilis. So you do an initial screen with non-treponemal, RPR or VDRL. If it's non-reactive, then they're negative. If it is reactive, they might have syphilis, so then you have to perform a treponemal test for confirmation. If they're non-reactive, then it was a biological false positive, they don't have syphilis, but if they are positive, then you would treat them. There's also a reverse testing algorithm. So you would do the enzyme immunoassay, or CIA, and then quantitative RPR. And then from there, if the RPR is positive, you have syphilis. If it's negative, then you would follow it up with one of those, the TPPA test. And then if it's positive, they have syphilis. Or, and that was a past or present infection. If it's negative, then it's just negative. Special diagnostic areas, so there is molecular testing available, patient monitoring, congenital syphilis, perform non-treponemal tests on the mother and infant at birth, and then IgM-specific treponemal assays to confirm. And then neurosyphilis, you're going to perform the VDRL or ELISA on cerebrospinal fluid. Other spirochetes. So Borrelia burgdorferi causes Lyme disease. Lyme disease is specifically transmitted by the Ixodes tick, also known as the deer tick. When you're evaluating ticks to see if it could or could not be carrying Lyme disease, you want to look for this hood, and this is an adult tick. So if you see this hood on an adult tick, this is deer tick. The problem is a lot of ticks, and the nymphs are really hard to differentiate. So nymphs come in late spring, early summer, and that's when they're first hatching out of their eggs. And if those nymphs have infected mouth parts, the nymph can easily go undetected. And that's what these ticks need in order to transmit Lyme disease, is they need to be attached for at least 48 hours before adequate saliva and bacteria is exchanged to be able to transmit Borrelia burgdorferi to a host. So if a tick manages to remain attached for like 2 days, it will be completely engorged, and at that point it's kind of hard to tell what type of tick it is. When the tick does come to the laboratory, if the patient pulls off the tick, sometimes they want to culture the mouth parts to see if the tick was carrying it, but then there's some tests that we can do on the patient as well. When they get to the adult stage like this, it's really easy to identify what the deer tick is, and it's important to note that not every deer tick has the bacterium. A lot of them do, especially in Wisconsin, and there's various random sporadic regions around the United States that have them, but especially in like the New England area of the United States. But just because this tick has been attached to you doesn't mean you're going to get Lyme disease. So clinical manifestations of Lyme disease, you get a localized rash and early dissemination. So you'll have this central, really bright part, and then you'll see this, this ring. It kind of looks like a bullseye ring that's forming around. Now, animals can also get Lyme disease, but typically, especially with like cats and dogs, you're not going to see this bullseye pattern. And it's hard to tell on a cat and dog because they have all that fur, but even if you were to shave their body, they usually don't react in this way. This reaction is kind of unique to humans. Then you have late dissemination with arthritis, and that's where the real anomaly comes into play, because even though we know that Lyme disease has the potential to cause arthritis, we don't exactly know how the bacteria gets to the joints. And a lot of times when we culture the joints, the bacteria is not even there. It seems as if the bacteria got to the joints, left some particle behind, and caused some local inflammation and some disruption, and that disruption leads to the generation of arthritis later on. So research is still out on the exact cause, and a lot of times, like I said, when you do end up getting that synovial fluid from the joints, it doesn't even have the bacteria present. So we screen with immunofluorescence immunoassay, or IFAs, or ELISA for antibodies to B. burgdorferi. Antibodies may not appear until 3 to 6 weeks after the tick bite. And then you confirm with a Western blot. Relapsing fever is caused by Borrelia miyamotoi. Sorry, I stumbled through that one. Transmitted by the same type of tick. Causes flu-like illness and a skin rash. Laboratory testing would be ELISA for the antibodies, or PCR may be used in the future. And then there's a summary that you can go ahead and read through.